is cheaper cost, at least to beginning you start the treatment. And until and unless you feel well, whatever be. So whatever, it's very difficult to feel that you are powerful, you are competent and everything. And I'm saying that many of my MS friends are here, so no doubt they are feeling well because their inner strength is very much. As I showed you, all this first attack gradually progress into relapsing multiple sclerosis from CIS, means clinically isolated syndrome, means a single attack. If you don't treat, what happened over the years, they develop a secondary progressive disease. What we don't want to. We want to be that the patient should be in relapsing and remitting format. The term relapsing and remitting means আমার একটা অ্যাটাক হলো, আমি ওষুধ নিলাম এবং আমার অ্যাটাকটা অলমোস্ট নিয়ার কমপ্লিট. The term near complete is to the tune of a 90% recovery I had, and তারপর আমি ওষুধ খেলাম যাতে আমার এই রিল্যাপসটা না হয়. But if the recovery baseline does not come, so suppose I had a relapse, so I took the immediate acute treatment, আমার তারপরে 60 ভাগ সারলো, বাট 40 ভাগ তো আমার রয়ে গেল. তার টপে যদি আরেকটা ডিজিজ হয়, সে যদি আরো 30 ভাগ সারে, তো আরো একটু এগিয়ে গেল. সো এই ফেজটাকে আমরা ইউজুয়ালি উই ডোন্ট ওয়ান্ট টু বি. সো নো ডাউট the worldwide the statement is you start early so that you don't see those secondary progressive cases early. And one of the interesting fact is that these secondary progressive cases which progress initially they would be active, means there is a chance of treatment even on a secondary progressive cases. At a time comes when they reach to almost advanced secondary progressive, then these medications do not work well. Regarding the treatment approach, I must say, because patients many a times comes and say to me, is there any changes in treatment? There is a little bit changes. So previously what we used to do, we start with a low and then go high. Means আমরা অল্প লো এফিকেসি ওষুধ দিয়ে স্টার্ট করা হলো এবং সেটা ফেল করলে হাই এফিকেসি যাওয়া হতো. And now the pyramid has flipped, because now the turn is you start with a high efficacy sometimes, the disease will come down and then you go back to the low efficacy. It does not mean যে আমি হাই এফিকেসি দিয়ে স্টার্ট করলেই আমাকে ওটাতেই চিরকাল থাকতে হবে. I can come down to the low one, but you start with a high to preserve the brain. That's a very good concept that sometimes to be, but this is not for every cases. Suppose that someone has a little advanced disease, much more patch, so we can think of having efficacy or intensive approach earlier to start the treatment will lead to better outcome. So it should be started to be early, and the most important, it should be a very shared decision. I was even talking to one of my MS friend that decision, it should not be like that I say and you take. It should be you have all knowledge what you are taking. কেন আমি নিচ্ছি, কেন আমি এতদিন কন্টিনিউ করব. It should not be a one day treatment. It's just like I have a UTI, I got the treatment and it's cured. It should be go on. So that should be known how much clinically I would benefit, how much radiologically I can benefit. That's things to be shared up. Usually sometimes we switch, means from, as I say, এক ধরনের ওষুধ থেকে আরেক ধরনের ওষুধে, সেটা লো এফিকেসি থেকে হাই এফিকেসি হতে পারে, হাই থেকে লো হতে পারে. এই কনসার্নটা তখনই আসে যখন একটা ওষুধ কারো এফিকেসিতে খুব ভালো কাজ করছে না, মানে আপনি একটা ওষুধে আছেন, ইন স্পাইট অফ দ্যাট ইউ আর হ্যাভিং রিল্যাপস, দেন ইউ হ্যাভ টু সুইচ টু এ হায়ার ওয়ান, or the medications is not tolerated by the persons, is not doing well for the persons. So clinically we look that you should have no clinical relapse, MRI should show no disease activity, there should not have any disability, and there should not have brain atrophy. As I showed you that picture, the brain atrophy is a concern nowadays. So there are many concerns. So should I take the injection, should I take a oral drug, how should it be given? People are busy, they don't want to take jabs every day or like those every week. They want, can I have injections in every 3 months, every 1 month, every 6 months? So there are many issues, tolerability, efficacy, risk how much is reduced, regarding the adverse effects and everything. But this is not to be discussed like here. There are these issues we can solve on an individual basis, and I like to be solved with an individual, because every MS friend is a different, every person suffering the disease is a different. I have to talk in a different way for the every persons depending on those things. I would just share the drugs that we have in India so much, like even with this, some few low efficacy therapy like interferon and teriflunomide, they are available. I started with an interferon, I told, but the protections by interferon is now shown to be around 30%. So the relapse that they prevent is near 30% sometimes. Teriflunomide comes as an oral tablet and belongs to the same category. But if we look into the high efficacy therapy, I have put the red mark on those drugs which are most commonly used actually in commonly. So dimethyl fumarate gives a protection of around 50% of relapse free, and it's available at a price tag of 2,500 rupees. So even with a high efficacy drug that is available in India as a capsule, so one can have, one need not have to jab or anything. So কোনো ইনজেকশনের দরকার নেই, দুটো ক্যাপসুল খেলেই হবে, and is very easy to monitor because you don't have to do lot of blood test. অনেকেই বলে আমাকে কি 3 মাস করে যেতে হবে, এত কিছু করতে হবে না. If you are good free, even a 6 monthly blood test with dimethyl is sufficient nowadays recommendations, but not for the initial period. So like those. There are few other drugs. If you do not respond very well, or if you had a relapse, so we can think of rituximab, a good drug. So a little costlier than those things, but the one good thing is that sometimes a single injection every 6 months is sufficient. That is one of the beautiful things that many patients, my patients, opt these things. The ones I will have, so I'll have 2 or 3 injections in a year, and I'm happy that I don't have to take any tablets or capsules. I will not forget, and its efficacy is a little higher than the dimethyl fumarate. And if you still relapse, then we have the options of natalizumab. Natalizumab is a little costly, and a monthly injection has to be taken. There is a hope for those patients with even primary progressive multiple sclerosis, means who from the very onset progress, means they don't have a relapse or a remit, হলো অ্যাটাক, ছাড়লই না, ওখান থেকেই প্রোগ্রেস করতে থাকলো. So we have ocrelizumab that is available. So all secondary progressive cases we can think of ocrelizumab. That's a good drug. There are other drugs like alemtuzumab is available and all those, but these are the therapies that are available. Even I should say just even dimethyl fumarate, which was 38,000 rupees, has come down to 2,500 rupees. So we can use even blanketly to many RRMS patients. So thinking of this is the first drug you can take like that way. This is not a promotion, just to we have the what therapies we are having. Teriflunomide is even no doubt is also cheaper. But in terms of efficacy, dimethyl fumarate gives around 50% protection, teriflunomide gives around 30 to 35% protection. So dimethyl fumarate with the same cost would be better because I will have much more protection. And rituximab is a fantastic drug to have because over the years you have to take only 2 or 3 injections in a year, and that is not, the cost is gradually coming down. There are many, apart from these multiple sclerosis symptoms, there are many symptoms that affects the quality of life. That is also important. They feel to be very fatigued, there are pain, tingling, and there are heat sensitivity, mood problem, urinary problem, and many things. Over these things we will address by my subsequent speakers little bit about the blood visions, about their therapeutic concerns and everything, rehabilitations and everything. So treatment should be based, one is the medications that we discussed, but that's not the enough. You need a good therapies, you know how to know to coping strategies, and no doubt a self-help technique. So no doubt every MS friend is a strong, funny, crazy MS warrior, and they must know they are awesome, no doubt. I salute and all this. Thank you.
Thank you so much, Dr. Datta. Our next speaker would be Dr. Professor Bibhu Kalyani Das. She would be talking about pain and palliation in multiple sclerosis. Today evening, what we have tried is we have tried to take an all-round approach to handle MS so that things become better for all our MS friends. That's the idea. So let's make the most of this evening.
মর্নিং ডিউটি করেছি যারা আছে তাদেরকে
খাবার চলতে
এই তো সুমনবাবু আছে, তো সুমনবাবু
fluid retention. So these things has to be addressed. This can be managed with modifying the dose, discontinuing the drug, and offering alternative treatment. So I don't want to bore you anymore. To summarize, living with MS, maintaining quality of life is possible by available medications and the palliative care. Pain management and rehabilitation with the two pillars of palliative care. People with RRMS can lead near normal life, and also span of life will not be that less. So we should be very hopeful and expand our palliative care facility from the OPD to home care, hospice. All these things we can do. And high quality person-centered care should be available to all of our friends when the diagnosis is made, initial diagnosis, or there is any suspicion of the diagnosis. So, not at a later stage. Just like your medications, you start early. Here also, palliative care, pain management should be started early when you suspect the disease. So, and along with that, your diet, nutrition, exercises, lifestyle modification should be available. And the family caregivers should be appraised and trained how to manage advanced cases. So here, anything you people can ask me, how to go for palliation, how to go for pain management. Pain management is one wing of palliative care, which is a very important wing. So these things, so if we together we work, together we help our friends, we'll definitely win. And we'll have people like this smiling with faces like you. So thank you very much for patient hearing.
Many thanks, ma'am, for such a positive message, and it was very informative also for sure. Next in the line is Dr. Rashmi Saraf. He's a consultant ophthalmologist in Iron Clay, and she will talk about something which we all have heard sometimes in our life, which is called optic neuritis. চোখের ব্যাপার। So চোখের ব্যাপার আমাদের সকলেরই MS এর মধ্যে আসে, it always comes some eye problem. So she's going to talk about that only. Ma'am, please. Thank you.
Very good evening to everybody. At the outset, I would like to thank the MS Society of India, Kolkata, for inviting me here for this talk. It's really an honor to be part of this program. So I'll be talking about eye involvement in multiple sclerosis, and I've tried to make it simple for everybody to understand, but I'll be happy to answer any questions. So why is eye involved in multiple sclerosis? So the previous speakers have said that, and we all know that multiple sclerosis is a disease of the central nervous system, which includes the brain and spinal cord. And there is loss of insulating myelin sheath, and the transmission of electrical impulses are slowed down. So this causes various neurological symptoms. Eyes are nothing but extended part of the central nervous system, and 40% of the brain tissue work for visual function. So eyes can be involved in the course of the disease at some point. Demyelination affecting the visual pathways result in visual problems. So here I've given a picture of the visual pathway. So these are the two eyeballs, and the optic nerve starts from here, and at this junction it is called the chiasma. The inner part of the nerve fibers, they cross, and the outer part goes in the outer aspect only, and they go and the visual fibers, they end at visual cortex, the primary visual cortex, which is primarily responsible for controlling the visual functions. So how common is eye involvement in multiple sclerosis? Eye manifestations are very common in multiple sclerosis. Majority of patients suffer from at least one episode of ocular involvement in the course of the disease. Optic neuritis or inflammation of the optic nerve may be the initial presenting symptom in 20% of cases of MS when they are not yet diagnosed with MS. And optic neuritis per se may affect more than 40% of people. So these are the different ocular manifestations of multiple sclerosis. As I said, optic neuritis, which is the inflammation of the optic nerve. Eye movement disorders, I'll be talking about this in more detail later on. Ocular inflammation, that means inflammation inside the eyeball. There can be certain adverse effect of drugs used in MS, which can affect the eyes. And there can be visual dysfunction in the absence of acute optic neuritis, like there can be low contrast sensitivity, subclinical thinning of the nerve fibers, and there can be visual field defects. So, optic neuritis, this is in more detail. It usually affects one eye at a time, which is it is unilateral. And patients often complain of pain around the eyeball or behind the eyeball, and which increases on eye movement. There's progressive vision loss over hours to days. There's loss of color vision, loss of contrast, that means ability of our eyes to distinguish a particular object against the background. And there can be visual field defects, covering from second to third week, and back we see visual acuity. Visual acuity is the ability to see small objects of small details of an object from a particular distance. Color vision, contrast sensitivity, pupil examination, fundus examination. This is basically the examination of the back part of the eye, what we call the retina, which I'll be talking in more detail. And certain tests on machines like visual level potential, perimetry, which is the visual field assessment, optical coherence tomography or the OCT, and neurological investigations like the MRI scan, CSF study, and blood tests. So this is a Snellen's chart by which we test the visual acuity of a person. And this is the Ishihara color vision chart, which is very important to diagnose optic neuritis. This is a chart of the contrast sensitivity test. Now, this shows how we examine pupil. So, in normal, this is the pupil, this black part in the center. So, in normal circumstances, when we shine bright light in front of the eyes, the pupil becomes smaller. And in dim light, the pupil becomes bigger because more light is needed in dim light. Now, in acute optic neuritis, the pupillary response is abnormal. So here, when we shine light in front of the eyes, the pupil will dilate in front as relative to the fellow eye. Now, when we see the retina, that is the fundus examination, there can be different presentations of the optic nerve, the optic disc. So this picture here, it is a normal fundus picture. This round thing here, this is the optic disc, that is optic nerve head, and this area is the center of the retina. This is what we call the macula, and these are the retinal blood vessels. So in 2/3 of patients with optic neuritis, we may not find any abnormality. The inflammation is at the back part and the optic nerve head is not affected at all. So this is called retrobulbar neuritis, and this is most common presentation. In some patients, we may find inflammation of the optic nerve head. Here we can appreciate this swelling of the optic nerve head along with this redness, inflammation. This is called papillitis. And a rare presentation may be inflammation of the optic nerve head along with inflammation of the surrounding retina. This is called neuroretinitis. This is a picture of the perimetry machine, the Humphrey Visual Field Analyzer in our eye department. And these are the pictures of visual field analysis. So in optic neuritis, we can have different kind of visual field defects. This is the visual field analysis of the left eye, both the pictures. In this one here, you can appreciate this black area. This is the normal blind spot which everybody has. So here the defect is in the center. This is the center of the eye. So this is a central scotoma, what we call. This visual field defect is very common in optic neuritis, a central scotoma. And this is a secocentral scotoma. Here the visual field defect extends from the center of the eye to from the center to the blind spot. These are also different visual field defects which we can encounter but not on a regular basis. These are not found in optic neuritis, but when the paralytic lesions affect the back part of the visual pathway. So in this picture, we see this is of the right eye, this is of the left eye. So here we see the person is unable to see on the outer aspect of both eyes. And this is called bitemporal hemianopia. And here, this is the right eye, this is the left eye. So here we appreciate that the person is unable to see on the left aspect of both eyes. So this is called homogeneous hemianopia. This is a machine which we have newly acquired, optical coherence tomography. This is an OCT machine. So this is a very important tool, especially in multiple sclerosis patients also. It is an investigative tool to measure the thickness of nerve fibers in the retina. Baseline OCT is very important because it tells us about the health of the optic nerve. It's very helpful in monitoring disease progression and quantifying the rate of neurodegeneration, and it also helps us to understand the neuroprotective treatment effect of MS medicines. In frequent relapses, there can be loss of retinal nerve fibers, and this indicates loss of nerve fibers in the central nervous system. It also helps in monitoring some ocular side effects of drugs like fingolimod, which Dr. Datta had spoken previously, because this drug can have some swelling in the retina. So this we can monitor with OCT. And OCT is also very helpful in clinical trials. This is OCT analysis of the retinal nerve fiber. It's very simple to understand. This is this round circle. This is for the right eye and this is for the left eye, and this indicates the health of the optic nerve. So the red color indicates thinning, and the green color indicates it's normal, and the yellow color indicates it's borderline. This is again OCT analysis of the retinal ganglion cell layer, that means the retinal nerve cell bodies. This is the VP machine in our hospital. Here the VP is in progress. VP means a visual evoked potential. Here the electrical signal produced by the brain is captured. The visual stimulation, when any visual stimulation is given, the brain produces electrical signal. This is captured by the VP machine. And it's very important to know about optic nerve treatment trial when we talk about optic neuritis. So it was a very large-scale study conducted in late 1980s, and around 450 patients were recruited. Patients were divided into 3 groups. The first group had intravenous steroids in cases of acute optic neuritis, and second group had oral steroids, and third had placebo, that means no treatment. And it was seen that patients who received intravenous steroid had faster visual recovery and lower rate of progression, but the final vision at 6 to 12 months showed no difference in between all the 3 groups. And 12 months, the 95% of patients showed very good visual recovery. So visual prognosis shown as to be excellent. And one more thing to be noted was there was higher recurrence rate in patients treated with oral steroids. Now, the demyelination can affect the other parts of the brain, which involves in controlling the coordination and balance, and also initiating eye movements. So, and the brain stem. So, when these areas are affected, patients can complain of double vision, blurred vision, ortholopsia, which means the object around us are appearing to be jumping, and there can be loss of depth perception. There can be deviation of the eyeballs, which can be either side to side or up and down. There can be nerve palsies, means the nerves which control the eye movements can weaken. There can be gaze palsy, which means when the eye looks to one side, it is normal, but when they look to the other side, the movement is restricted. There can be involuntary jerky eye movements called nystagmus, and there can be disorders of fixation. That means the fixation can overshoot or undershoot when something is looked at. And there can be ocular inflammation, which is called uveitis, which can affect the front part of the eye, which is called the anterior uveitis. And the presentation is with pain, redness, light sensitivity, and blurred vision. The uveitis can affect the middle part of the eye, which is called pars planitis, and it causes floaters, pain, blurred vision. And sometimes the retinal veins can also become inflamed. It is called retinal periphlebitis, but this can be silent without producing any symptom. So to conclude, visual evaluation is an important part of MS management, and visual prognosis in MS is generally good. With modern treatment under neurological care, visual functions can be well maintained, and in advanced cases, sometimes low vision aids may be helpful. Thank you for your patient hearing, and I'll be very glad to answer any questions.
Thank you very much, ma'am. I think it's very important to know what's happening with our eyes and how we can handle and make it better, right? We want to see well and see properly, right? Our next speaker, another very popular and a very well-known patron of MSSI, which is Dr. Suparna Gangopadhyay. He will be talking about rehabilitation in multiple sclerosis, an overview of that. So it's very important, of course. So let's hear from him. Thank you.
Thank you, everyone, and good evening to everyone. Thank you, MSSI, for giving me this opportunity to speak on rehab approaches in multiple sclerosis. So there are a number of slides here, but I'll try to make it as interesting as possible so that it's helpful for you all, and I'll be okay with any questions in between or even after. So without wasting any time, I'll just move into the slides. So just a little bit about the background. We need to understand this. Multiple sclerosis is a chronic neurological disability which leaves a patient with a significant long-term disability burden. So the need of comprehensive rehabilitation. What does evidence say? That a multidisciplinary structured rehabilitation program benefits patients. This is an extremely busy slide, but just imagine, it's so difficult to run through these symptoms. Just imagine how a patient of MS has to cope with these symptoms. This is a vicious cycle of multiple sclerosis where I won't read out the words, but definitely what it means is this is basically a vicious cycle which has to be broken down, and that needs to be done by a multidisciplinary comprehensive team where it's a patient focused team approach with the neurologist at the helm, and we as the rehab specialists are a part of the support team. Interesting slide which explains a lot of symptoms which a MS patient bears with, how to manage them. So let me just divide my talk into four subgroups. Initial, I'll just mention about the physiotherapeutic approach, later on the next ones. Now, so we need a very thorough assessment where we need to identify the felt needs of the patients, prioritize and identify the goals. These goals just shouldn't be a goal which we think, but it should be a realistic and a functionally focused goal which will be ultimately beneficial for the patient. One very important sentence there is regarding group therapy, because initially what happens, you might need that individualistic approach to the patient, but later on, once you have that group therapy, I think the involvement, motivation of the patients increases further. This is the crux of your exercise protocol, which involves aerobic exercises, strength training, flexibility training, balance and power training. I am not going into the details of this, but this is what a team does. Explains the home therapy which the patient continues at home. These are very important adjuvant therapy for a patient who has been diagnosed with MS. Aquatic exercises, which shows physical and psychological benefits which can actually improve our quality of life. One of the very important and irritating invisible symptom is fatigue. But studies have shown that an intensive combined rehab program could effectively decrease fatigue. And it has shown that the improvement in strength only happens in a non-fatigued state, not in a fatigued state. Strength training, why? To improve so that we can prevent falls. This is something which is very important. Virtual rehab, which we have in our setup. Why is it important? Because it is motivational and a very effective treatment, alternative treatment to the traditional conservative approach. Something very irritating for the patients, social embarrassment. Rehab helps with pelvic floor exercises, and studies have shown that women have been much more comfortable after doing these exercises. Vestibular rehab. Why? Lot of patients suffer from dizziness, balance issues, and vestibular problems. Studies have shown that significant changes in fatigue. So, one thing is for sure, that all these rehab programs have some benefit in improving fatigue, which might not be expressed, but some symptom which is not visible, but this is something, if that is improved, your overall quality of life improves. So exercise actually improves balance, disability due to dizziness, or even your equilibrium status. So what was the multiple sclerosis healthcare community conclusion? I need to read this out. All patients need a comprehensive rehab, cognitive, psychosocial and therapeutic treatment tailored to the individual needs, as one size certainly does not fit all the patients. Very important, equal weight should be given to medicines as well as the psychosocial model, which includes rehab as well as psychiatry. My next short discussion will be on occupational therapy. Probably you might be thinking what exactly it is, but it actually, whatever you have learned from the physiotherapists, improving your muscle strength, that is actually translated to your functional outcomes. It enables the patient or you all to participate in your daily activities. What do they do? Thorough assessment, identify the occupational needs of the patients, evaluate the ability of you all to see whether what sort of roles you are able to do, you are able to carry out, evaluate safety, and ultimately there is a huge need of your environmental modification, because you need to be a part of the society, a part of the environment. If you can make your environment friendly to yourself, a lot of you actually have won the battle to a large extent. Again, fatigue. I am not going into the details of any of these slides, but I still feel the important culprits for fatigue is sleep disturbance, medication side effect, and the extra effort that you all need to put in for your daily activities. Thorough assessment is needed. A patient actually describes their day-to-day fatigue in their own words. We need to figure that out, flesh out the problems and then treat them with two strategies. One is how to manage energy management strategies. The other is the energy conservation strategies. Now, energy management strategies, lots of things are there. One basic thing, healthy lifestyle. Three things, three mantras of life: good sleep, daily exercises, and healthy diet. This is true for everyone, be it a MS patient, be it a non-MS patient. So that actually improves your energy. Conservation, few things which I'll just mention here. Please schedule most difficult cognitive tasks when you are more alert. That will conserve your energy. Take adequate rests in between. Doesn't mean that you need to sleep. Simplify your work. Pace your work in short steps. Prioritize. Simplify your tasks and delegate your tasks which you are not able to do. Very simple words, but I think this will take away a lot of burden of fatigue from you, so that you can utilize that saved energy for something else. I think it's to see so many patients with MS at this hour of time, beating the heat of 40 degrees plus. So this is amazing, but I'm sure every one of you follow these very simple techniques, but I'll just mention them once. So how to manage your heat problems: temperature dysregulation, wear light clothes, loose fitting clothing, try to be in a cold chain. It's not possible for everyone, but at least try to do your exercises in a cool environment. And please take rest in between activities. Upper extremity dysfunction, most important is spasticity. I think there are a lot of MS friends who might have experienced spasticity during your course of this disease. There are medicines. Again, these medicines can lead to your fatigue, worsen your fatigue, but the best is to go for non-pharmacological treatment. We have a hand clinic which will assess your spasticity level and prepare splints for you, or even take care of your hand issues and improve that to a certain extent, which can definitely help you to improve your daily activities. There are a lot of patients who might feel tremor and incoordination, but again, important points from here: you need to follow the home exercise program properly, have frequent breaks, and we can also provide adaptive equipments like weighted cuffs. That helps a lot to reduce the tremor. Visual rehabilitation. There are medicines might not work always, so at the end you will need visual rehabilitation. There are a lot of techniques, conservative as well as technologies. We have our VR system here, so that might also help you to improve your visual coordination to a certain extent. Again, important thing, falls prevention, that has to be taken care of, and as early as possible, so that you do not end up in fracture. Speech and swallowing will be my third intervention. So very quickly, more than 1/3 of people have swallowing issues. Males with more than 15 years of disease are at higher risk of developing swallowing problems. Females are actually saved. So the impairment happens in the oral phase and also in the pharyngeal phase. Like when you are making your bolus, when you are trying to uh, chew the food, to make a bolus, to help it to transit normally through your food pipe. So problems might happen in either of that. Signs and symptoms: difficulty drinking continuously and difficulty taking large amounts. Severe impairment. The worst thing which we are actually worried about is frequent chest infection, which might lead to an aspiration pneumonia and an ITU admission. So we investigate through a functional scope, camera, interventions again, exercises, and a few compensatory mechanisms. This is a very important thing for people who have difficulty swallowing. So a safe swallow protocol needs to be followed. Important things: sit upright with chin tucked down. Give the patient time to swallow, both liquids as well as solids. Smaller amounts, thorough mastication before swallowing. Please do not talk during eating or drinking. Manage fatigue. How to do it? Use snacks and have bigger meals earlier in the day. The same thing as cognitive issues. And please avoid mixing liquid and solid food in the same mouthful. So this is a very important slide, I guess, for people who have difficulty swallowing. Modify the texture. The swallowing pathologists do that. People who have difficulty swallowing liquids and solids. And now quickly run through the speech difficulties, where mechanism of speech production is affected. Other can be from the cognitive part, the language difficulties. Naming is a problem, naming might be a problem, and the list continues. How to manage? Language therapy, and again oromotor exercises. Something new which is coming up in the horizon is brain-computer interface, but again these are in the experimental phase. But if they really work, it will be a good thing for people who have difficulty with their speech and language. I will end with this because my next speaker, he is going to speak a lot on that. But rehabilitation psychology in management of MS is a very important topic. So a role of rehab psychologist and social worker is quite important. The ultimate goal is to empower you all, manage your circumstances and challenges autonomously. You all need extensive psychosocial support from the families as well as from the experts. So we are there to support you. We're just a phone call and a consultation away. Now, very quickly, I think everyone who suffers from any sort of problem runs through this dabda phase, which actually is initially, why has this happened to me, means a denial phase. Then it comes anger. You bargain, you ask God, cure me, I'm going to give you this. That doesn't work. You get depressed. Forget about everything. Now I have to move on, accept everything and move on. So this sounds like a very small word, but I think the expertise is needed to run you through that whole process. So here, cognitive behavioral therapy works quite well. Again, it is a comprehensive approach. I am not going into the details. The moot point is there are people, experts to support you. If you need help, we are always there. I'll just finish my talk with this. There might be a lot of people who would need these disability certificates and benefits. Actually, the Rights of Persons with Disabilities Act has multiple sclerosis included in their chapter, which says if you all ever need a disability certificate, you have to go and collect that from the government setup. But for that, they, like, if you are consulting any private specialist, we can actually refer you through whatever assessment we have done. That might become easier for the doctors in the government institute. Thank you.
Thank you so much, Dr. Gangopadhyay. I think the concept of DABDA, something new and very interesting. Thank you for highlighting that and enlightening us. It's wonderful. And how deep probing is useful in handling and managing MS. That's also very important. And the help of aids, how they can better our lives. That's also very, very important. I think that's wonderful learning. Thank you so much. Now, our next speaker would be Dr. Praveen Kumar, as the cue was given already by Dr. Gangopadhyay. Yes, of course, there are a lot of issues in the mind, different levels, different times, but when we are affected by MS, a lot plays in our mind, and how we can manage it better, I'll request Dr. Praveen Kumar to share with us. All yours, sir.
Thank you. So, good evening, everyone. So, I'll be speaking on psychological aspects of multiple sclerosis. We know that, like, what are the most common mental health issues which are seen in persons with multiple sclerosis. So, depression and anxiety disorders are the most common mental health problems which are seen in patients with multiple sclerosis. They can occur at any stage of illness. So sometimes they can be just initial presentation of the disease. Sometimes multiple sclerosis can just present with depressive symptoms. Or it could occur at later stage of illness when person experiences more challenges related to their illness. They need not be present in all individuals, but majority of them experience these symptoms. So, depression in MS. How to identify depression in MS? So, those patients who are experiencing depression, like, what are the symptoms? They feel sad most of the time. Nothing interests them. Not enjoying anything which they used to enjoy before. Lot of fatigue. Negative thoughts like, I am not being useful. There is nothing to look forward to. They feel that they are not contributing enough, and sometimes in severe cases of depression they get ideas of harming themselves. So that's why it is important to be aware of these symptoms, and the data says that around 30 to 35% of individuals with MS experience depression. So depression in MS, is it just a symptom or is it a reaction to MS? Sometimes patients may be reluctant to report mood changes. See, depression, we say that we suffer silently, because in our there is a lot of stigma associated with expressing mental health concerns and seeking help towards the mental health issues. So sometimes patient may be reluctant to report mood changes, and sometimes depression in MS often presents with more of irritability and frustration rather than the more typical withdrawn behavior. They might be just become more angry, more irritable. They are getting they get easily frustrated. So that might be just sign of sign of depression in MS. So depression presents in males differently compared to in females. In men, depression men, they don't report like, I'm feeling bad. The way the symptoms which are seen in men are more of irritability, more of anger outburst. This is a common but very incorrect assumption that it is normal for a person with devastating chronic illness like MS to be depressed. So, we think that depression in MS is just related to psychosocial issues. No. The research says that it might be related to the illness itself. So changes in medial inferior frontal cortex, reason, the lesions in specific part of the brain also can contribute to the depression. And sometimes depression may be due to the common psychosocial issues which are seen in MS: uncertainty about future, inadequate coping strategies, helplessness, poor social relationships, lack of recreational activities, high levels of stress and fatigue. So these all factors contribute to the depression. Now, what are the anxiety disorders which are seen in patients with multiple sclerosis? Around 25% of patients with MS experience anxiety disorder also. So most common which are seen are generalized anxiety disorder, panic disorder. And what are the anxiety symptoms? How to identify these anxiety symptoms in patients with multiple sclerosis? So those who are suffering from anxiety disorder, they feel they are anxious all the time. They worry a lot. They have difficulty in concentrating. They might get irritated in minor things, heart beating faster, sweating. They can't relax. They worry a lot about small trivial things. When it comes to living with multiple sclerosis, anxiety often stems from uncertainty over what the next day will bring. So what are some other common mental health issues which are seen in multiple sclerosis? Another is substance abuse. The smoking and alcohol use, it not only affects just mental health, it also affects the multiple sclerosis disease itself and the treatment. And we also encounter sometimes patients come with psychosis in patients with multiple sclerosis. That might be sometimes related to treatment of multiple sclerosis itself. And we see also the bipolar disorder sometimes in patients with multiple sclerosis. So medications sometimes like steroids can also contribute to such symptoms. So how are these mental health problems assessed in multiple sclerosis patients? Now, when a person gets a diagnosis of multiple sclerosis, there will be a period of sadness, shock, worry or anxiety. But these emotions are quite normal, but they are for a period of transient time. But when these symptoms persist beyond 2 weeks and significantly impair their sleep, appetite, and they are constantly thinking about it, then they need a detailed psychological assessment. So the diagnosis of depression is done by clinical interview, and some scales help us to diagnose depression in MS patients. Now, how do we manage depression in or mental health issues in MS? So as I said, like mental health issues, maybe it might be sometimes medication related. Although there are a lot of research or controversy whether interferon B can cause depression, yes, or steroid can cause sometimes depression. So sometimes it can be medication related, sometimes MS related, multiple sclerosis illness related, or it might be related to psychosocial stressor. So we have to assess the severity of depression and anxiety, and also is there any suicidality. Accordingly, our management differs. But what is good news is depression in MS can be treated. And there are two different approaches. One is psychotherapy, or what we say counseling in general term. And the approaches like cognitive behavioral therapy, mindfulness based therapy have been shown to be very effective in treating depression. And there are a lot of studies on like which medications are safe and effective in treating depression, especially in multiple sclerosis context. And there are few RCTs which have shown that medications like desipramine, paroxetine, mirtazapine and bupropion, which are devoid of sexual dysfunction, these medications are helpful in treating depression as with multiple sclerosis. And we have got a new molecule which is called vortioxetine, which helps both cognition and depression. When we talk about mental health issues in multiple sclerosis, it is mood and memory. These are the two important domains which are affected in the multiple sclerosis. And there is also called pseudobulbar effect we talk about. Sometimes patients, they have sudden uncontrolled expressions of laughter or crying without an obvious trigger. So sometimes it's very distressing for families and patients themselves, like they feel their emotions are not under their control. But these symptoms can be just a part of MS itself. But there are treatment options. They can be successfully treated with certain medications like amitriptyline and SSRI. And there is also a new molecule which has been approved for this treating pseudobulbar effect in MS. Now, when we talk about cognitive changes, what are we talk about the mood, but the lot of research on, there are a lot of cognitive changes which happen in patients with multiple sclerosis. They have problems in processing speed, that means slowness in information processing. They have difficulties in learning, difficulties in memory, difficulty in concentrating. So they can occur at various stages of illness. Sometimes it might be just due to the comorbid anxiety or depression. So, so this was one the very interesting article which found that now how to improve the cognition. Especially this article, they found that intellectual enrichment is linked to cerebral efficiency in multiple sclerosis. That means it improves the cognitive reserve. So those people who are having intellectual enrichment means those people who are active with respect to reading, active with respect to social activities, active with respect to learning new things. And the study found that these people cognitive reserve is very good, and it's a protective factor in multiple sclerosis with respect to impairment of cognition. So it's also seen in even in all elderly people who are active intellectually. Like active means like they are reading books, they are socializing, and so they are learning new things. So these people, the research says that the cognitive decline is less in these people. Now when it comes to improving memory, so find interesting and challenging mental activities to do regularly, increase physical movement or exercise, create a routine for yourself so that improves, and use external memory tools, so improve your sleep and nutrition. Now, when we talk about MS, it is not just the patients, it is about the caregivers. So, what is the impact of multiple sclerosis on caregivers and family members? So, when we talk about any long-term illness or disability, it puts a lot of stress on caregivers. I work with also children with autism, so where I see that it puts a significant impact on caregiving, and they suffer silently. And sometimes we think that yes, it's our duty. So sometimes, but sometimes these caregivers can also have stress. They can also have anxiety. They can also have depression. So caregiver burden is high in the context of multiple sclerosis. This results in reduced quality of life. So impact of caregiving itself creates a lot of difficulty. People, because caregivers, they need to know lots of information about what's new in multiple sclerosis, and also financial management also comes into the picture. So depression and anxiety are more common in caregivers as well. So that is very important message. So what is the goal? What is the goal is making a person little more independent or as functional as possible within the constraint of physical disability. And second important is caregiver, more accommodative environment helps the patients, more flexible approach. So be just flexible with respect to dealing. No, you have, so that puts a lot of stress. So just being flexible will help. And for caregiver also, do not hesitate to take help. So I was reading about yes, illness and all. So but there is one factor. So people have looked into, there are some people who are suffering from multiple sclerosis, but they are very strong. They do not suffer from any mental health issues. How this is happening? So people looked into, there is a factor called resilience. Some people are very resilient, although they have illness. And people looked into what are such factors which are associated with these resilient individuals. And people found that those people who regulate their emotions, they are very resilient. Those people who have better control over their impulse, they are resilient. Those who have realistic optimism, those who are optimistic despite adversity, they are very resilient. And those who think logically or casual analysis related, and those who reach out to others, they are more resilient. And the word which I would like to say is self-compassion. Research has shown that self-compassion is one thing which has been consistently shown to be associated with resilience. What is self-compassion? Just being kind to oneself. That is supporting self with kindness and understanding instead of judging or criticizing oneself. This has been shown to be associated with resilience. So we should be kind to ourselves and to our family members. So every day matters. That means so the simple activities which can help patients is like writing gratitude journal, meditation, altruism. Altruism is one thing. So one study looked into like two multiple sclerosis patients, where one patient was helping another multiple sclerosis patient. Now people found that a person who, both of them were benefited, but person who was helping another multiple sclerosis patient, he benefited more with respect to mental health point of view. So it is the helping others definitely improves the mental health. So that's why the idea of this societies coming togetherness, helping others, sometimes it forgets to an extent that we get so engrossed in this activity, we forget that we have such illness. So that is the message, very important with respect to keeping ourselves busy in some activities, helping others. So helps us to forget our disability and think positively. So invest in social support. And there is an entity called common humanity. It is not like I am the only person who is suffering. No, there are people like me, yes, they are also suffering. So I am not alone in this world who is suffering from this issue. So that's why the concept of common humanity, where perceiving one's experience as a part of larger human experience rather than perceiving them as an experience that would isolate them from others, is important. So what are some protective factors? I spoke about some protective factors, that means which help us in protecting us from depression. So people who talk to others about their feelings, responsibility towards community, connectedness to the individuals, family, community, problem solving skills like ability to adopt or change, religion or spirituality. Sometimes it has been shown that people who have got some association with some kind of religion and spirituality also helps them in coping. 1 hour of extra sleep helps everyone as a protective factor against depression. This is what I want to say. But although we are day by day we are reducing our numbers of sleep, and being optimistic and being flexible is very important. And this is my last slide, where this was an American Psychological Association. They said that some few tips they said to just help us. What are those things? The form strong relationship with your family, friends, and community. That is first important thing. Second, view big problems as a solvable or adaptable. I always look towards my chairman when I tell about this. Whenever there is a problem, he says there is a solution. That is the way the approach is. So view big problems as a solvable or adaptable. Appreciate change is a part of life. So change is constant. So make goals, take actions, improve yourself, think positively. Sometimes be hopeful and take care of yourself. So this is a fantastic book if somebody wants to read, because Anthony Feinstein is a psychiatrist who has dedicated his entire psychiatric career just in studying mental health issues in patients with multiple sclerosis, and he has written a fantastic book if somebody wants to read on mental health issues in multiple sclerosis. This is the one reference. Thank you.
Thank you so much, sir. I think the importance of care